So good morning. Can I have the microphone? Good morning, everybody. Have a nice lunch. I'm very pleased today to introduce that session, which is on innovation in pelvic floor disorder. And I have the privilege to present to you a short introduction before to leave the three eminent speakers that are on my left during this different lecture. We thank Neomedic International to have sponsored this lunch symposium about global innovations in pelvic floor disorder. This is my disclosure. I'm from the southeast of France, and thank you for the welcome we have in the US for this Congress. So in 2019, the FDA notification has dramatically decreased the use of vaginal mesh in the US, but also in many countries all over the world, and it was the case in France, where it's not possible anymore to use mesh for vaginal repair. However, the experience we had with vaginal mesh for about 2 decades has deeply changed our practice in terms of uterine sparing surgeries, of the anterior approach to the sacrospinous ligament suspension, and the use of specific device for this ligament suspension by the anterior approach. In last year, the ICI recommendation has focused on the vaginal sacrospinous hysteropexy, which is the preferred option for uterine prolapse surgery with uterine preservation. And as you see, there is the possibility to do it by sacrocolpopexy as well. In terms of sacrocolpopexy, should be normally reserved for vault prolapse. About sacrocolpopexy, some colleagues think today that it's the gold standard for apical repair, but there is some issues about sacrocolpopexy. The learning curve is long. Operative time is long as well. There is a great variations of techniques for sacrocolpopexy, and in two recent RCT done in Europe, the rate of conversion from laparoscopy to vaginal surgery was between 6 and 9%, showing that it's not the right technique for all our patients. And there is also one long-term studies that have been evaluated efficacy of sacrocolpopexy, and if sacrocolpopexy is really efficient for the apical compartment, you see that after 7 years, there is almost 20% of recurrence in the anterior compartment, and even more for the posterior compartment, showing once again that sacrocolpopexy is not the right procedure for all our patients. Apical support plays a major role in cystocele repair, and we all know that when doing vaginal surgery for prolapse, it's really important not only to treat the anterior or the posterior compartment, but to fix the apex at the same time. In the recent AUGS IUGA joint terminology about surgical technique for pelvic organ prolapse repair, the 3 different possibilities for apical fixation by the vaginal root were the uterosacral ligament suspension, the sacrospinous ligament suspension, and the iliococcygiosis fixation. And we will almost talk about the sacrospinous ligament suspension in this symposium. About the advantages of the anterior approach of the sacrospinous suspension, it's efficient for both level 1 and level 2 repair simultaneously. It makes the vaginal axis more anatomical after the procedure. It's possible to perform a concomitant anterior native tissue repair and anterior sacrospinous suspension by a single incision. It's obviously easy to perform a uterine preservation, even if hysterectomy at the same time is also possible. And it leaves the option for a future laparoscopic sacrocolpopexy in case of recurrence in the anterior compartment or in the apex. It was first published by Roger Goldberg about more than 20 years ago, and in that retrospective study, it has been shown that the anterior compartment is well repaired by the anterior approach to the sacrospinous ligament suspension, while the posterior compartment is a bit less repaired if you do the anterior approach for the sacrospinous ligament suspension. There is, from 20 years, only few studies that have been evaluated safety and efficacy of anterior sacrospinous suspension. Most of the studies are small studies, no RCT at that time, and most of the studies have been done with hysteropexy, but some with concomitant hysterectomy. As you saw at short-term follow-up, the rate of success at the level of the anterior of the apex is very good, between 96 to 100%, and the rate of success for the anterior compartment could be good as well, but not so good as we normally had with mesh surgery. And in this different publication, there is some complication, and there is some complication about post-operative pain. In one recent study we've performed in France with the bilateral anterior approach to the sacrospinous ligament plus native tissue for the anterior repair, we had a 4% post-operative pelvic pain, and that will be one of the discussion we had with the next speaker. So may I introduce you now Dr. Conrad Duncan, with urogynecologist in Baltimore, and we will speak about the approach, the anchoring system for the sacrospinous ligament suspension. Thank you.
Green button, right? Which button is green? Green. Thank you for coming and spending time this afternoon. That's me. It's my Hopkins email address, and if you have a pen, I'll give you my phone number because it's easier to text me because I never check my email. The phone number is 443-514-8247. I'll give it to you again at the end. You can send me comments or questions. Hi, Sherelle. You got it? Get it from Sherelle if you don't. She has it on the bathroom wall. And if you ask scathing reviews or whatever, send them via text, all right? I'm going to move quickly because I prefer to do questions and interaction. There are people here who have used AnchorSure, people who have comments and things to say that might be beneficial for everybody, maybe more important than what I have to say. My wife says I talk too fast, I talk too much. She's not here, so here we go. My job is to make this very boring instrument exciting for you today. So let's see what we can do. Green button, right? Top green. Ah, that green one. All right, so the AnchorSure was introduced in Europe in 2009. Here in the US, FDA approved in 2012. It's the first anchoring device marketed worldwide and the first with RTCs to show that its efficacy. It's made of polyether ether ketone, used widely in orthopedics and dental. So it's got the material has wide use in the human body. And has a pull-out strength of about 50 newtons. No matter what you utilize as your force measure, that's about twice of what is physiologically important in the human body. So it does not pull out very easily. It's compatible with bioscaffolding, and as I will show you, let me back up one slide here. This is the kit. That's dinosaur size there on the left. The real size is to the right there, where you see it compared to the end of a ballpoint pen. So that's the kit. It comes loaded with a polypropylene 0, and that can be changed out if necessary. Versatility of AnchorSure. You can reach the sacrospinous ligament anteriorly or posteriorly, and of course bilaterally. So the device can be placed as a 4-point fixation for those who like 4-point fixations, especially with a hysteropexy. It can be used in cases of massive prolapse. At the end of the talk, I'll have a QR code which shows you the repair of that, plus a bread and butter repair, so that you'll have an idea of actual placement. We don't have time for too many videos for this today, but the QR code will show you. When I do the QR code, once you flash the QR code, it takes you right to the video. If you're caught looking at videos after my talk, your phone will be taken from you because we have other presentations, okay? As mentioned, it can be used with bioscaffolding. or as native tissue. And the anchor can be placed in the iliococcygeus fascia. That is a legitimate apical support. And on the rare occasion that you cannot palpate the sacrospinous ligament, it happens on a rare occasion, it's an adequate placement there into this iliococcygeus fascia. So down here, you'll see that the device compared to a finger. I can tell you that the incremental benefit from AnchorSure is about the same that we got from using open surgery, or open vaginal surgery, to devices such as the Deschamps ligature, or Deschamps as they might say in Texas, and myohooks. They're all about the same in terms of placing a suture. The incremental improvement of those devices is about the same that we've gotten now with AnchorSure. It is a pure tactile placement, so that what you do with the AnchorSure device is to simply follow your finger in after you've palpated the ligament and punch the device in. Safety is built into the device on a number of levels. One, the travel distance is limited. You cannot go through the sacrospinous ligament. The device has a distinct tactile feedback, so you know when you're in the ligament. It feels incredibly different punching it into the ligament than the muscle, or the fascia, the iliococcygeus muscle. It also gives you feedback with sound. It has a pop sound that makes when you're in the right place. You absolutely know when you've correctly placed it. This we may be familiar with. This was in the special submission. Catherine Matthews looked at gluteal and buttocks pain with the Capio device and with AnchorSure and found that there was no difference in the pain. The Sufu abstract talks about the speed improvement using an anchoring device. It was statistically significant at 86 and 120 minutes, respectively. I don't know how the anchor improved that much in terms of speed. It is actually a faster placement, but that seems a little bit high in terms of how quickly it would, how much it saved. My experience with AnchorSure, I've been using it since 2017. It was at AUGS that I ran into their booth. They had a very small booth at the time, and Javi was sitting in the corner. And it was as we made that transition away from mesh kits, and we were looking for other options for anchoring or fixation with or without scaffolding in mind. And I started using it then. I've had over 1,200 procedures done and over 3,000 anchors placed. Now, I've not had any complications directly related to anchor. I had 2 extrusions. Those were both iliococcygeus placements, and I was using permanent suture at the time. I now use PDS. Don't ask me why I was using silk. I had this thing with spiders. That's definitely changed. I have a mean time when a multiple compartment repair, anterior, posterior apical, and a perineural free of about 120 minutes, 112 minutes. It is compatible very well with same-day surgery, especially with organ-preserving surgery, hysteropexies. Most patients do not need narcotic medication, and that is both a testament to our collectively moving away from them as well as patients not needing it. The decreased volume of dissection is incredible with the AnchorSure compared to any other method of reaching the sacrospinous ligament. Literally, it is a change in anything we've learned in residency or fellowship because it is purely a tactile placement. Literally, palpate the ligament, keep your finger there, purchase the device on the ligament. I stand up so I have a perpendicular placement, and I close my eyes and pop it in. There's something to be said, literally closing your eyes, you get better tactile feel. You do not rely on any visualization. And it's a different surgical subset than what we've learned in the past. I don't know any other procedure we do that. This is just a cartoon showing the placement. QR code for the videos. Again, there's a video, a bread and butter video for sort of a routine repair, and then I have the video for the massive prolapse. They are essentially the same. The device is, I almost always do a 4-point fixation. and a bilateral and anterior posterior. So I think we're going to have questions now for this. We only.
Thank you very much. Do you have any question in the room? I don't have any access to the virtual question at the time, but perhaps it will change. Any question for Dr. Duncan?
Mm-hmm. Yeah.
Okay. Do you have a microphone? If you can just wait for the microphone, please, because there is some people connected virtually.
We have about 300 folks online watching, so we'll need to use that.
No, just wondering if you're working with a trainee and you don't like their placement in the ligament,
Right.
What are your options at that point?
It's a great question, and it scares a lot of people to the thought of having to leave an anchor behind. So you're asking two very good questions with that. One, what happens if you, and this will happen when you actually do the pulley to get your apex up and the suture breaks. That will happen on occasion. It's a zero suture, and all of us can break a zero suture on occasion. Sometimes if you're not careful, you can get tissue rolling up into that pulley and it'll break. So that's the first part of that question. The second part is, if you don't like the placement they've made, the first question is, where do you think they put it, right? If they put it into soft tissue, it's relatively easy to pull out. If they put it into sacrospinous ligament and you think it's too medial or too lateral, you won't know that because you didn't actually palpate. So I hesitate to say that you have to have residents and fellows who are sure on how to locate the middle third and lower portion of the sacrospinous ligament before you let them fire the anchor. So once it's into the sacrospinous ligament, that's a difficult pull. Soft tissue, easy to take out. If it breaks, the concept of leaving it behind is actually very simple. You leave it behind. We leave, bullets in people all the time. It's a bad analogy, but that's absolutely okay to do. Okay? Is that okay? Yes.
Hello, I'm Javier Pizarro from Chile. So just a quick comment. First of all, thank you for citing our study from SUFU. So we use AUGS regularly, and in terms of like the placement, and if you don't like the placement for the fellows or the trainees, this is one of the great things of AUGS that you don't have with Capio or other devices, because it's a stiff system. So if you can touch the sacrospinous, you can put where the system will go, and then you remove your finger and you show the fellow, there is where the anchor needs to be. Then you take it out and you say, try yourself. And before he deploy it, he take out his finger and you touch it again. So if you want to avoid that thing, the anchor is already there, you can train them before they deploy it, and you cannot do it with Capio or other ones. Right. And actually, I talked with the guys from Neomedic. I was able to remove some of the anchors in one case that the patient has with like persistent pain after like 4 months from tons and tons of different anchors that I placed before. And you can take it out if you need it. That patient particularly, she had pain, we take it out, and the patient went away. So one of the good things, if it's a stiff thing, you can check it before he put it in.
And that's a great point, because you can actually follow their finger or follow where they've placed it and make sure that it's right where it needs to be before they deploy. That's why I said you have to make sure they know where to put it. Great. Yes, sir.
You can take the microphone, please.
Mike, is the mic?
Do you make the fluidius ligament for this? You make fluidius ligament or not?
In terms, I'm sorry, do you palpate or?
You palpate this ligament.
Merely palpate. The dissection into the perivesical perirectal space is the same as it would always be to reach that, but the dissection is literally a finger dissection, palpation without visualization. So all you need to do is feel where you are, and the device will follow the back of your finger, and you know where it's placed.
Okay, and you don't make free ligament.
Oh, you mean free it up to visualize? I mean, taking away all the tissue around the ligament? Is that what you're asking? I'm sorry.
Yeah?
No, not necessary.
Okay, only for one finger.
One finger. That's it.
Okay.
That's it. Just one finger. I think we're running. I'm probably short on time. If we have time at the end, we can answer more questions or online.
Thank you very much. We now move on a presentation about single sling incision. Recently, we have seen a clear evidence-based studies on the incision sling. Abdel Fattah study in the New England Journal of Medicine with great success of single incision sling. And we have the pleasure to introduce Dr. Teresa Irving, which practices urogynecology in Central Texas. She's the president of Caring Center for Women. She's a robotic surgical proctor and expert witness. She founded the Vaginacologist, which is an online educational and social media platform, because she realized that many of these issues our patients were experiencing were due to the lack of education. She's a mother of 3 amazing sons and also had an incredible granddaughter who has seen trained how to whip from front to back after peeing. So thank you very much for your presentation of single incision sling using needleless.
All right. Thank you, Dr. Duncan. So I started out in OBGYN in 2000 private practice. And then with the grandfathering in process, I became board certified in urogynecology. So anyway, those are my disclosures. And I've come full circle because starting in OB, where a lot of the damage begins, and then now to be repairing all of those disease processes that occur as a result of childbirth. Now, in the January of 2022, in the American Urologic Association Journal, it showed that 60% of women will end up having incontinence at some point in their lives. And that's just crazy. It's going up all the time. So my goal is to help these women so that they don't have to worry about looking fat in their diapers, or they don't have to be looking for sexy diapers like this lady here got the thongs and is bringing sexy back, but her spouse isn't too keen on the idea. Anyway, this is one of my favorite videos. My granddaughter. Anyway, having a lot of fun. And sometimes crazy thoughts go through my head. And I think, oh my God, I got to do my Kegels so I don't pee on my granddaughter. But what if Kegels are not enough? So Neomedic has created some excellent devices to help us treat our patients so they don't have to worry about peeing on their grandchildren. And Neomedic to the rescue. I'm going to be talking about the single incision sling, the needleless, and this is a polypropylene macroporous 1,000 micron sling. And it's been FDA cleared since 2010, so it's got 12 years of experience, mostly in Europe. And then it has 522 post-market surveillance studies that were completed in 2015. So in this study that was in 2014, it compared the TOT, the full-length TOT, to the needleless, and it showed that the results were comparable. And this was done over 3 years. So objectively, the results were 87.7% of needleless and 88.9% of the TOT had a negative stress test, and subjectively, it was 93.2 and 94.5. We're satisfied. And I don't know about you all, but I'd rather have my patient happy than me be happy. So I definitely like the subjective being better. And then what was different, though, was the post-op pain, which was greater in the TOT arm. In this study that was published in 2018 in the International Urogynecology Journal, 201 women were studied. They were put on either the needleless or the full-length sling arms, and they were studied out to 24 months. And basically, you get this essentially the same results, where subjective results are better than the objective results. And the mesh exposure rate was less than 1 centimeter, was found to be the same in both arms, 3.4% for both groups, and then more than 1 centimeter, it was 2.2%. And just like yesterday in our balloon conference and discuss, figuring out what is the best treatment, surgical treatment for stress incontinence, this challenges it and says, can the mini sling become the gold standard for treating stress urinary incontinence? And this was published in 2020, November. And it basically looked at the 2 randomized control trials comparing both slings, finding that their efficacy and safety was essentially the same, except that the difference was the post-op pain. And it seems like the length of the sling is the key, where the needleless is 11.5 centimeters, while the full-length sling is 19. And since it's not going through the transobturator canal, it seems like that dissection, the lack of the dissection is making the pain less in the needleless arm. Now, why do I use the needleless? Well, truth be told, the rep that sold the device, really, he had approached me initially after trying to get past the guard that I have at my office, the firewall, more than 6 months, and finally got through. He introduced me actually to the Remix, which I won't steal Dr. Kenley's thunder, let him speak to it. But anyway, it solved a lot of the problems that I was having with my problem children patients that had ISD or recurrent stress incontinence after an incontinence procedure. And then, because I had great success, he said, hey, you want to try the needleless? And I said, well, you know, the Remix is great, so sure. And as it turned out, it was very safe and effective and user-friendly. And it has 3 major differences from the regular mini sling, which is length, surface area, and positioning system, which I'll address now. So you can see there the length, where is this light? Yeah. The length is 11.5, no, this is not working, 11.5 centimeters versus the mini sling is 6.5 centimeters. So you're going to have greater urethral support. In addition, the surface area is 2.5 times that of the mini sling. And then the third feature is that it has the pocket positioning system versus an anchor positioning system. Further elaborate here. So you can see the comparative lengths. And now, why is this length important? Well, there's a study done on 35 pelvises where they measured the distance between the urethra and the proximal portion of the internal obturator muscle, and they found that to be 35 millimeters plus or minus 5. So obturator to obturator would be 70 plus or minus 10. And let me go back. And the acceptance criteria is that the minimum sling length should be the distance, more than the distance of the from the urethra to the proximal portion of the internal obturator muscle. So here, in terms of surface area, you can see that the TOT and the needleless are very similar, 16.08 and 16.5, while the mini sling is 6.5. And the reason for the difference is because the pockets are the same material that the rest of the sling is. And because the pockets are also folded over and it's doubled on both sides, that increases the surface area. So again, more urethral support. Now, without anchors, is it going to be effective enough? Because you don't have that hold, so to speak. And as it turns out, the force that's exerted by a coughing blow to the urethra is 43 to 48.5 grams. And that of the pull-out force of the needleless after implantation but before closure of the vaginal wall is 866 grams. And that's 17 times more than what is needed for a coughing blow to the urethra. Now, the pocket positioning system is the third feature that makes them different. And here, so as I mentioned, it's the same material, same polypropylene macroporous material that is going to be integrated as the way that we like this sling to work. And the entire length of the sling will be integrated into the patient's tissue, so it acts as a unit and not all cattywampus. While the anchors that are polypropylene also, but they're solid material, our bodies normally form an encapsulation around a foreign body. And because it's also only into the pelvic floor muscles, and we know that those do descend over time, then the mechanical support can be lost over time. While the needleless is going to the internal obturator muscle, which is primarily a fixed muscle. So my data, yeah, I can't show off like Dr. Duncan over here. So I started 2019. I've done almost 200, but I've done many, many more prior to that time. And I do have follow-up with the majority of my patients, as far as I know, and they're doing well. My success rate between 85 to 90%. I've not had anybody with inguinal pain because it doesn't go through the obturator canal. And main complication being UTIs, which I treat with a week of antibiotic prophylaxis postoperatively. My mesh exposure, has been 2%, and they were all under 1 centimeter. 2 I took to the OR, 1 because she was going to have a concomitant rectal repair, and the other one didn't want to do it in the office, even though it was going to be a minor excision. So here are the surgical steps. To load the sling onto the tonsil tip, you insert it into the pocket, spread it open, and then you're going to push the center of the pocket to close it. I want you to notice how I'm taking the tonsil tip forceps handles and they're being palmed in my hand. That way there is better control in the placement. So once you've dissected your space, which is going to be towards the endopelvic fascia, full thickness vaginal mucosa, and the incision will be 2 centimeters longitudinally. You're then going to listen for 2 pops, one that goes through the fascia and one that goes through the internal obturator muscle. And the goal is to have the central blue thread about 1 centimeter deeper in relation to the urethra. Once you go to your contralateral side, then you're going to insert that second arm until the central blue thread rests under the middle of the urethra. And that will then elevate the urethra to give it support in the middle. We know that is the weakest point. And you'll see how in placement, I do place 1 finger in between the urethra and the tonsil tip forceps to protect the urethra. And you can see it's nicely laying flat. It's not folded, so you don't have any banding, don't develop any pain. Then all you need to do is cut the suture and then close the vaginal mucosa. Okay, so it doesn't take too long. So in conclusion, comparing the needleless to the full-length TOT, results are comparable, less inguinal pain and adduction problems, and can be done under local, minimally invasive. And in comparing it to the mini sling, less anchor pain with the 3 feature differences. Boy, those words are off there. Being the length, pocket positioning system in the surface area, and it's also the first one to have their FDA post-market surveillance studies. And with that, have y'all ever wondered why baby diapers have brand names such as Loves, Huggies, and Pampers, while undergarments for adults are called Depends? Well, here's a lowdown. That is because when babies pee in their diapers, we're still going to love them, hug them, pamper them. But when old people pee in their pants, it depends on who's in the will. And with that, I thank you and open to questions you may have. I'll leave that there.
Thank you very much. Please stay with us for the question. Do you have any question for Teresa?
I may have to like plagiarize that joke. It's funny.
Please do.
All right. In the interest of our carbon footprints, there is an advantage to this because, obviously we have the trocar. My only concerns, well, first of all, since it is no trocars, is it cheaper than the other mesh kits that we have?
Yeah.
Because that's the value analysis committee is going to always ask me those kinds of questions and where it meets a need. But my other second question is because we have some history on doing some mini slings, is the adjustability once it's placed, being able to, it's not quite tight enough. I mean, you can use your finger, whatever, but I want it to actually be a little bit tighter and vice versa, that adjustability.
Yeah.
Thank you, though.
Thank you. So thank you for your questions. And regarding the first question on cost, that actually was kind of a driving force for me because it was a relative amount of savings. But, it's going to depend, obviously, on the contracts that you have with the hospitals. And then regarding the second question, no, you can't adjust it once it's placed, but it is placed so that it is snug against the urethra. Not super tight, but just literally just hugging the urethra. So, and I haven't had any issues with that. I haven't had to transect. So, yeah. But I understand what you mean by that, for sure. But there is, Dr. Kennelly's going to talk to you about an adjustable one, which is awesome. Any other questions?
If you can take the...
They're better.
Thank you very much. It's a great speech. I'm going to have only one question. Ist the needless for each and every patient for hypo and hypermobility of urethra, and do you do something like measurement of urethra length or not? And how it is indication for needleless and for Remax? Can you say something about
Sure,
that?
absolutely. So remind me of the first one. I remember the second two. On your question, your first one? Oh, the measurement, right? Yeah. So yes, I do measure. I go about 1.5 centimeters because the width of the sling is 1.2 centimeters. So we know that the average length of the urethra for the female is 3 to 4 centimeters. So that's how I take my. That's how I determine the measurement. And of course, you can tell, by feeling the bladder neck if it's 3 or 4, 3.5. So accordingly. And then versus the Remix, when I don't use the Remix as a first line, I use it if it's a patient that's failed a prior anti-incontinence procedure, and then, or if they have ISD. And then in terms of the hyper or hypomobility, so I don't use it on hypo, I use it on hyper, the needleless. So is that it? Did I get it all? Thank you. All right, thank you so much.
Thank you very much. The last part of this presentation will be on adjustable slings, and we have the pleasure to host Michael Kennedy, which is professor in the Department of Urology and Gynecology and director of Charlotte Continence Center in North Carolina.
Yes. Thank you. And unfortunately, I don't think I have good fancy QR codes or jokes, but sorry about that. But today we're going to really talk about kind of the adjustable component of things. If you really look back, these are my disclosures. If you look back at the index SUI patient, straightforward urethral hypermobility, we know from evidence that there are some really good operations out there. Birch coupled suspension, we have slings, including autologous, synthetic slings, but there's also artificial sphincters and bulking agents. That's where the evidence is at. But when you think about it, what are we really striving for? We're striving for the ideal surgery. After 100 years, we still haven't gotten the ideal surgery. And the main reason is because we haven't had long-term durability. Unfortunately, recurrence of stress incontinence or the difficult patient is there. And that's why we're going to talk about sort of an adjustable sling. Could that be one arm in your solution to help these patients? If you think about it, TVT has been revolutionary. But between 2 and 16% of TVT patients right away don't have success. In addition, over the long term, success decreases. And if you look at sort of patient populations at 10 years, it's around, quote, success, 70%, but really dry rates are in the 30% range. And that's for autologous fascial slings and for TVT synthetic slings. So I think what we're looking at is how can we improve these patients? We know that people who have high BMIs, patients who have low urethral tone or a non-mobile urethra, patients who have significant urinary incontinence are the people that are at risk. And unfortunately, we don't have many options as far as readjustability once the sling is put in the operating room. So my experience with all this goes back in the 1980s. I started doing autologous fascial slings. Great operation. I still utilize it. However, there is morbidity to that. In the 1999s, I moved over to TVT as things evolved into TOTs and really single incision slings within the 1997 era. And then it was really, I've been in the same location for the last 27 years. And when you're in the same spot for 27 years, your patients will come back and you start to realize that, wow, some people are having recurrences. And so that's when, in 2016, I started looking at the Remix sling, because could that be the answer for some of these patients who have immobile urethras, recurrent stress urinary incontinence? So the sling has actually been out and approved in Europe for over 20 years. That started in 2001. In America, it came out in 2009. So there's long-term history within this sling. It's a very simple type of sling. It has a 3.5 centimeter mesh part by 1.2 centimeters, polypropylene arms. It goes up in the retropubic space. It has a varitensor, which is an adjustability over the pubic symphysis, and then a manipulator to do the adjustable area. The keys to it is it's a post-operative adjustability. So you have total control over the patient has their involvement to be helping you if you want that. So the other key thing about this is the mechanism of action. Remember, this is a circular sling. It's all the way enclosed. And so that there's dynamic transmission that's occurring that because the veratensor is closed above the rectus fascia, when someone coughs or strains, it's pulling up on the suburethral component. You also not only have the underneath component, but the periurethral arms that really add to that support. So the technique, if you've done any type of retropubic sling, it's very similar, which is nice. So midline incision, periurethral dissection, passing a trocar around the periurethral area behind the pubic symphysis. Once that's in place with cystoscopy, you'll put on the polypropylene suture threads, pass those to the suprapubic area. Usually through a 4-centimeter incision, you'll dissect down to the rectus fascia. The veratensor will then be put in place to adjust it. You'll then adjust it down usually to about 3 to 5 centimeters. You definitely want to keep it super loose at this point in time. And then at that point in time, you'll close it with the manipulator outside the body. Normally, the patient will go home with the same day without any type of catheter. As far as adjustability, it's really how you set up to do that. In our situation, we bring them back to the office. When they come to the office, we backfill their bladder to 350 mLs. We have them stand, undergo repeat cough stress testing, and if they're leaking, we continue to adjust the manipulator in a clockwise fashion until you get to the point where they stop leaking urine. At that point in time, we then have the patient go to the restroom, have them do a uroflow, assess their posterior residual to make sure that it's adequate. If a patient feels that they're comfortable at that point in time, we then will remove the manipulator. But if they don't feel they're comfortable, we may have them go home, come back the next day to remove the manipulator. Removing the manipulator is very simple and easy. Anyone in your office can do it. The nurses, the MAs, just a counterclockwise quarter turn. It comes out very easy. You can put a steri strip over that area. So who are the candidates in my mind for this type of sling? For my situation, it's really for someone who has recurrent stress incontinence, mainly recurrence from a retropubic midurethral sling. Someone with a TOT, I may potentially do a retropubic sling in that situation. But the ones that I find the most are really the non-mobile urethra, ones that have poor urethral tone. In addition, people who have maybe chronic coughs, tracheostomies, people that are really aggressive coughers because I want that dynamic transmission to hold that in place. Additionally, patients who are large and high BMI. And then the underactive bladder is always a difficult patient because they balance between incontinence versus voiding dysfunction. There's a very small, narrow window, and so that patient is one that I sort of choose. It's certainly offered to the index patient, but in my sort of population, it's sort of rarely chosen. But who would I not? This is an implant. This is just like any other implant, so you have to have good technique when you're placing it. So patients who have a high glucose, they're really not great candidates. Wait till they get their glucose under control. Immunocompromised people are not good. Radiation patients are not the ideal. I think the other aspect is you identify urethral diverticulum or you have a urethrotomy at the time, don't use a synthetic sling, maybe use a biologic at that point in time. But then the key for these patients is remember that this is an implant. There are potential issues that may need to be removed. However, if you ever have to remove one of these, it is the simplest remove of all the synthetic types of slings. So the benefits that I see when I look back, when I'm comparing it to my autologous fascial slings, is really over my career, clearly this is easier on the patient. It's a quicker, faster operation, easier to recovery, less pain, less discomfort. They're not having to do any type of catheterization at all, which is really nice. And then the added benefit is that there is potential adjustability where they have their involvement to decide when they like the continence and they're satisfied to remove it. So I think that is beneficial. But the key is also, what about the data? This has been out there for a while. How come you haven't heard about it, as the next best thing throughout? Well, when you look at it through the last 20 years, they've really now accumulated, there's about 7 different studies. These are sort of single center studies, long-term going from 2 years out to 7 years. They all have differences regarding what success is, but predominantly all are cough stress tests. Some are looking at pad weights. And successes are typically within the 80% range in those long-term studies. What I'd like to do is kind of focus on two of the longer studies because I think these are two good studies that have been done. This study that's out of Barcelona looked at 205 patients at 7 years, and they broke those patients up into recurrent stress urinary incontinence patients, which all had a prior surgery, many of them TVTs, and then also intrinsic sphincter deficiency, which is a non-mobile urethra, a urethral pressure profile less than 20 centimeters of water, and leakage with minimal motion. And what you're seeing here is at the end of 7 years, and this is 3 surgeons that have been doing this at the center, you're seeing that even in the intent to treat population, it's a 71% success rate. And that success is by a negative cough stress test in addition to a pad weight test. Now, the number of readjustments that were needed during this time was averaging about a third of the patients needed 1 readjustment, up to about 3 years out. It's very rare for people to need 2 adjustments, extremely rare for people to need more than that. But the complications certainly can occur. They broke down the complications in the Clavin grade. Most of them were Clavin grade 1 and 2. There were only a few that were Clavin grade 3. 10% had detrusor overactivity. You had 2 urethral erosions, 2 urethral vaginal exposures, and then you had 2 suprapubic varotensor infections, and those required surgical removal. The other study is out of Italy. This is a 7-year data on their very first 50 patients. This is a select group only with intrinsic sphincter deficiency. So this is ISD, non-mobile urethra. In here, they had roughly about 40% of the patients had had prior surgery. And when they looked at here in this analysis, where success for them was perfectly dry at stress testing and a pad weight, 1 hour pad weight, less than 1 gram. You can see here they had 90% of their patients were successful, which is very good at that point in time. The Clavin grade, they also looked at it. They did have patients who had urinary retention, which they had to decrease, and they did not have any type of exposures at that point in time. So once again, durability was there. So in my kind of summary, where do I see this fitting in? Because we do have very many options. I think the benefit is that the adjustability, if you're going to use it, that's the key. It's a very simple operation. If you're used to doing retropubic slings, this is where it's at. As far as afterwards, if you want to have the patient involved in their degree of continence where they're satisfied, this allows that ability. It's a little bit more time intensive on your staff and your office to be able to do this, but if you want patient satisfaction in the right patient, that's it. And then I think long term, it's been reported out to 16 years, they've been able to go back and readjust this area. It's an outpatient or an office under lidocaine procedure to be able to do that. So I think the data is out there. We have a lot of studies, more than 150 publications that have been out there. But for me, this is really for the patients who have recurrent stress urinary incontinence, people who have intrinsic sphincter deficiency, really poor urethras with minimal hypermobility, and for that patient who has underactive bladder, who has really low voiding pressure that does not want to catheterize, this is probably a better ability to do it because then they have the ability to be with you deciding what is the right amount of tension that they'd like. So thank you.
Thank you very much. Any question from the floor?
Hi, thank you. Quick question. One of the things I saw in the research was there was tensioning parameters based on newtons.
So no, during this
there
type,
were 3 different levels of tension that were provided in the table, and it looked like a Newton force. No?
not in, that might have been in Dr. Irwin's.
I used newtons when I was talking about the anchors, but
Is it, can we see that slide by any chance? The table? It was just so interesting. I was curious if they actually could measure the difference in tensioning. Can you choose a tensioning level? Is it based on a click, or how do you tension?
For the remix?
Yeah.
For the remix, no. It's purely just a turning
And so
ability.
you don't know how much to turn to tension?
Well, you're typically tensioning during cough stress testing. And normally, if you do 3 turns, it's about 1 millimeter of movement.
Okay.
So there is a mathematical calculation that you can do to do it, but it's not under a tension aspect.
And then 10 years out, when you're readjusting,
So 10 years out, you have the ability to still do sort of a clockwise turn to tighten. As far as loosening, what tends to happen is the polypropylene sutures that are along the arms, they don't encapsulate. And so it's really the encapsulation is really the under suburethral component of that. And then the varatensor just has a capsule around it, and that doesn't really matter. So you have the ability more to tighten. I think loosening after 5, 6, 7 years is going to be challenging.
So you tension just based on cough stress test?
Correct.
Cool.
Yes. You can certainly do that, yes, because the polypropylene doesn't, it's not scarred in it anywhere. Right, and I think that's the key to having it 3.5 centimeters in length that allows just that periurethral support.
Quick question. Hey, so the learning curve, you were kind of alluding to this. What do you think would be the learning curve for someone that does traditional retropubic synthetic midurethral slings? First question. Second question, conceptually, do you ever wonder about causing trauma to the urethra without the patient realizing it, just getting to that point where they're continent and then going home and coming back a couple months later with some sort of erosion into the urethra because of the delicacy of that tissue?
Well, I think so. Two things. The learning curve to this, I think there's a lot of proper skill set in learning about proper technique and avoidance of infection. And it's also picking the right patients to begin with. Patients have to understand this is a little bit different. As far as erosion, really it is so loose to begin with that you're just doing adjustability. The movement that you're doing is so small that minor area, and for the ones that had erosion there, I think, once again, those were intrinsic sphincter efficiency, really poor urethras. Also, a lot of them had prior slings. In my perspective, I actually take out the retropubic sling suburethally prior to putting this in.
Gotcha.
Hi, Abner Santos from Guatemala. Nice presentation, thank you. I have one question, and it's regarding the MRI imaging. It's any issues that we have to have concern when we are sending a patient to an MRI, pelvic MRI, for example?
Yeah, so the varatensor is MRI compatible, so you're allowed to be able to do that. But as far as now the 3T and others, I have to check on that from the manufacturer.
I had a couple of comments I wanted to make. So in terms of the surgical, the threshold, or how long it takes to learn this, I have an excellent surgical assistant, so it actually saves me time. She starts at the top and is doing the cut down up to the rectus fascia, so but when she's there, I'm already coming in with the needles, the trocars. So that's a way to save some time. I've done adjustability on the day of surgery, depending on how they're doing, and have not had to go back to change that. So that's another thing. If in between surgeries, if it's the first case, you can come back later and adjust it while you're there still at the hospital or surgical center. And there was another point, but I forgot. I have early dementia or something. Okay.
Thank you very much. Last question from the floor? And no question from you.
I have one more comment. Cheryl Iglesias brought up a good point about cost. The anchors are cheaper than Capio, just in terms of when you have to present it to your value committees. So it's going to be an important point.
Thank you very much for this comment. Thank you very much for all the speakers about this different subject, and thank you for Neomedic International to organize this symposium. Have a good afternoon, everybody.